Hello and welcome everyone. We start with our live sessions of Prosthodontics. I am your mentor, Dr. Ruchi Raj. Today we will be starting with complete dentures. The plan for taking prosthodontics is to divide the entire syllabus over the course of 7 to 8 days. We will have sessions every evening. I have divided the course according to its weightage as well as the trends that are being followed in prosthodontics. Initially, first we will be covering complete dentures, then I'll move further with removable partial dentures, then FPD, and lastly we will be covering fixed partial dentures, then some implants, TMD, and some portions of full mouth and occlusion. Now, before I start with today's session, I just wanted to briefly discuss how prostho in toto is a subject for NEET preparation. We are all very well aware that prostho is probably one of the largest or vastest subject in dentistry. Like I said in my last YouTube live session, that we start teaching prostho from first year BDS and it goes on till final year BDS. And there are a lot of subspecialties involved in prostho. Now, does the same pattern follow in NEET MDS or your INI exam? Honestly speaking, we need a very focused approach to learn this subject because for NEET MDS, the strategy of preparation is slightly different. As we are very well aware that we have a total of 19 subjects that we are preparing for our exam, we can get overwhelmed with one subject and start preparing it in depth. I am not saying that it is wrong to do so, but sometimes you will lose precious time by overspending your time on one subject. So what do we do with that now? So because of this particular reason, I first want to explain to you how to start prostho as a subject for your NEET MDS preparation. It can be a slightly daunting or intimidating subject for you, but with our sessions and with our strategy and schedule, I hope it will be very clear and easy for you to prepare this subject. So if we see prostho as a whole, mainly what is asked in exams is complete dentures, partial dentures, and FPD. And the fourth section, if I call it miscellaneous, then from that TMD, occlusion, implants, and other miscellaneous sections such as full mouth or other aspects are usually asked. Now, what I have observed as a trend in prostho over the course of last few years is that main weightage is given to conceptual questions from CD. Out of that also, if I list out the important areas, they are anatomical landmarks, then effects due to age or aging, impressions, face bow and vertical dimension, then troubleshooting, and phonetics. These would be my most important listed topics out of complete dentures. The entire of complete dentures is very important for your prostho MCQs. The general trend that you observe over the course of last 10 years is that you will see almost 50 to 60% of weightage either going to CD or to RPD. If we come on to RPD now, what is asked is the indication of different components. So whether it be a major connector, a minor connector, a direct retainer or an indirect retainer, usually the indication of different components is asked. Second thing which is asked is impressions. What are the different impression procedures? Third topic which is very frequently asked in exam is surveying. And fourth is block out with the different waxes. That is very commonly asked from removable partial dentures. If we look at FPD, what is very commonly asked are simple and straightforward questions. So FPD is very straightforward, nothing to beat around the bush as such. It is very simple and straightforward. Mainly it is pontics, abutments and abutment selection, and finish lines that is primarily asked. and something about cements and tooth preparation. More commonly, we have seen these areas out of FPD. If you look at these sections, they would constitute maybe 10% of your questions sometimes. The number can vary over a period of time. It is not a fixed 10% quota that is given to it. If you are preparing for NEET or if you are whether new for NEET preparation, you must be aware that there is no fixed syllabus or there is no fixed division and weightage of a subject in it. There could be a exam where it could be majorly prostho oriented. There could be an exam where you will find very few questions. So when we are strategizing for our exam, we need to focus on certain areas. So what I prefer is called as a focused approach to our exam. What this does is that it increases your probability of answering the questions in exams because you are preparing the trends of these topics better. Does that mean that we do not prepare other topics? No, but I would suggest that you focus on these topics better, or you rather give weightage to these topics more. So we would go for a focused approach for our MDS preparation regarding prostho. Second important thing which I want to tell you is that with me, I always prefer that you do a concept or a concept based, right? So a concept based preparation, which means that you focus on understanding the why behind everything. Why does this happen? Or why is this particular mechanism behind this procedure? Or why is this particular numerical value used for this impression material? Or why is this thickness of spacer? I'll try and explain you the why behind things. The reason is that if you have a core concept around a topic, then it becomes easy to remember, or rather it is engraved in your memory. You don't need to memorize it. The main important reason for doing so is what? Because at the end of the day, you have 19 subjects which just cannot be revised last day before the exam. You just cannot revise everything last day before the exam. So you need a organized approach towards preparation, wherein what we do is that we develop or we build core concepts of our subject that are there in our memory, and so we do not need to revise it last day before our exam. So that is my basic strategy or basic approach towards preparing this particular subject. Now, how do we start reading prostho? I would suggest that you start with the section of prostho that you're most familiar with, or the one that you probably think you know better. Start solving about 20 to 25 or 30 MCQs per day. Read the explanation. If there is a particular section which is out of these topics that I've listed and you are completely unaware of it, go back to your synopsis or a standard textbook or refer to our videos that we are there in the recorded section, and then you can revise that section and start solving the MCQs better. This is how you practice it over a period of time. Try to increase the number of MCQs to 50, 100 or even 200 per day. Come back and keep revising what you have already solved. The reason is that if you do not revise what you have solved, then probably there is no use of it. Rather than learning new things, it is always better to revise what you have already done. So that would be my strategy to prepare for this particular subject. Now, today we start with complete dentures. So in complete dentures, the first today's class that we have, what I'll cover is your anatomical landmarks. Second topic that we will cover today is the clinical exam of a patient. Then we will move further with age-related changes on the tissue. We begin with impression procedures in complete dentures that would cover your primary impression, border molding, secondary impression, and your posterior palatal seal area. The goal is to cover all of these topics in depth with proper understanding to you so that you will be able to solve questions. All of these are very important topics. When we discuss these topics, there is a lot that would still remain undiscussed or probably uncovered. But since I have observed the questions from the last 15-20 years of papers, what is more asked primarily is where my focus would be while discussing these topics with you, right? So let us begin our today's session with the first topic, which is your anatomical landmarks. Now, as you are all aware, anatomical landmarks in complete dentures is a very important topic. You start learning these topics actually from your first year preclinical prosthodontics, wherein you see on a model or a cast what are the different anatomical landmarks, you draw them, identify them, and then you understand them. If you are supposed to read it from textbook, I would suggest one particular textbook, which is your Boucher's or Zab Bollender. You could take up the 11th or the 12th edition and try to read it up, or you could just refer to our notes and understand it from them. So, what are basically anatomical landmarks of maxilla and mandible? Your maxilla and mandible intraorally is made of a group of structures which are normal structures present in a completely edentulous arch. Why do we study anatomical landmarks? So what is the reason for studying anatomical landmarks? The first and most important reason is to identify the abnormal structure or a pathologic structure from a normal structure. So if there is a normal structure present in the mouth, and if there is a pathologic structure, by knowing the normal structure, you will be able to identify the pathologic structure present in the mouth. Second important reason is to study the different architecture of structures present in the mouth. So if you notice, there are various supporting, limiting, relieving structures present in the mouth. All of them have different architecture because they are made of difference in bone as well as mucosa. Somewhere you will find non-keratinized mucosa, somewhere you will find keratinized mucosa. So we need to understand the difference between all of them. Third is to effectively design your prosthesis by knowing the in-depth understanding or getting an in-depth understanding of your anatomical landmarks. We would actually be able to design our prosthesis very well. So these are my three top reasons why we need to study our anatomical landmarks. Now, I will first start with anatomical landmarks of maxilla. So anatomical landmarks in maxilla or in mandible also are briefly divided into three main parts. You have your supporting structures, you have your relieving structures, and you have your limiting structures. Why do we study anatomical landmarks? The reason for it is that you have different intraoral structures which will have an underlying bony architecture, a mucosal architecture, a submucosal architecture that varies from structure to structure. By knowing the anatomical landmarks in detail, we would actually be able to understand the physiology behind these structures and how would a denture employ these structures for its retention, support, and stability. That is the primary reason for understanding these landmarks. The dentist would develop a full, thorough understanding of the structures present in the mouth. Now, I'll give you an example. Supposedly, I identify that my palate is a structural shape which will not give me sufficient retention, or my posterior palatal seal area or soft palate is of a particular class or type that is insufficient for retention. By identifying it from the first step, I would be able to effectively do a treatment plan that would give me or offer me better retention. So I could search for alternate retention means. Secondly, I could inform my patient the outcome of our treatment. So the patient is aware and has proper expectations for the treatment. So this is a very clinical reason why we actually identify and examine these structures in detail. So we should begin with the gross anatomy of maxilla. Grossly, if you see, or if you see the basic osteologic anatomy of maxilla, it is actually a paired bone. It is actually a maxilla. It is a plural form. So there are two maxilla which are united in the center at the mid-palatine suture. So it is a paired bone, and grossly if we see, it is pyramidal in shape. It is like a pyramid that you see, and there are mainly four processes that are there surrounding the or of the maxilla. Mainly, if you see, it is a pyramidal shaped bone and a paired bone that unites at the mid-palatine suture. There are multiple relations of maxilla on the anterior surface, posterior, medial, and lateral. We will not go into the details of it, but the main structure that we need to understand is your supporting structures, first of all, or the internal structure of your maxilla. So we'll shift to the now next page. This is what is very important. This particular image has been taken from vouchers. So I'll start explaining this image to you after we cover some part of your maxilla. Second image that here mainly shows the anatomy of maxilla. If you can see here, this is your maxilla present. And posteriorly, this structure which is highlighted is called as the pterygoid hamulus. It is a very important structure at the posterior border. Before that, what you see, this bony structure here is called as the maxillary tuberosity. It's the terminal part of your denture, and it is roughly placed. It will be maxillary tuberosity will be roughly placed above the third molar. It will form your posterior extent of the denture. Medial aspect of this tuberosity, if you see, it is slightly rough. Medially, it is slightly rough. What we see in a lot of extraction cases is sometimes the molar comes or breaks off with the tuberosity. That is actually very detrimental for a complete denture, because now you don't have your secondary supporting area for the denture. So very key area in terms of complete denture fabrication. Most important point that needs to be considered here is on the lateral aspect of the maxillary tuberosity. It gives origin to which muscle? Just give a thought to it. It gives origin to medial pterygoid muscle, right? So medial pterygoid muscle will originate on the lateral aspect of your maxillary tuberosity. It is very important. The photo here I've incorporated mainly to make you understand that our denture should end somewhat here. If it overextends onto the hamulus, because the hamulus looks like a claw-like structure like this, and if the denture impinges over it, it will cause a sharp pain to the patient. So that causes a very sharp pain to your patient. So that is very unfavorable with the denture. That should not be there, right? There are four processes of maxilla. Roughly, if you see, you have frontal alveolar process, zygomatic process, and your palatine process of the maxilla. That is about the gross anatomy of the maxilla. Now, if we need to actually divide the anatomical landmarks of maxilla, like I previously said, we will first have our supporting structures. So supporting structures. Second, we'll have our limiting structures. And third, we'll have our relief areas. So grossly, we have these three sections under which we can divide our maxillary intraoral structures. right? The supporting structure, the main structure for support is your hard palate. Second area for support is your residual ridge. These are your main supporting structures. If you see as limiting structures, you have labial frenum, then labial vestibule. Similarly, you have buccal frenum, you have buccal vestibule. Then you have a structure posterior to tuberosity, which is called as hamular notch, and then you have your posterior palatal seal area. Together, if you unite them, they will actually, so you have a frenum anteriorly, labial frenum, then you have your labial vestibule, then you have your buccal frenum here, then you have your buccal vestibule. Then we have our hamular notch posterior to the tuberosity, and in between them we have a posterior palatal seal area. So if you unite these structures as a whole, they form the outer limit of your denture, which means that a denture should not extend beyond this. That is why they are called as our limiting structures. So that would make up the limiting area of the denture. And third is your relieving areas. Now, relief areas are what? The areas which cannot take up stress or which cannot take up load, that are called as relief areas. So, if we look at relief areas, you have incisive foramen or incisive papilla, which is present over the foramen. You have mid-palatine raphe. These would make up your relief areas, and you have your cuspid eminence, which is a bony eminence around the canine, which should be relieved from the denture, right? So these are your grossly all structures divided into three headings: supporting structures, limiting structures, and relief areas. Now, what exactly we mean by support over here, or what exactly do supporting structures do? So, support as a property is what basically, there are mainly three properties for any prosthesis, which is called as retention, stability, and support. I'll explain you support today. Support is that property which is there in a prosthesis that will help bear the vertical forces that are generated during different functional activities. So something that will help bear your vertical forces generated during your functional activities, such as, I'm trying to explain it to you in own native words rather than the exact GPT definition. So these functional activities could be swallow, it could be speech, and it could be chewing. Now, understand one process with me here. We swallow multiple times every minute. If all of you that are listening here, you're sitting in rest position of the mandible with the teeth slightly apart from each other. Now, when you swallow, your teeth momentarily come in contact, and that generates vertical forces of occlusion. Whatever may be the magnitude, some amount of force is always generated. This force, say supposedly this is a denture. This force is exerted on the teeth that goes through the denture bearing area, and then denture base, and then it goes to the denture bearing area, and ultimately it goes to our bone which is present underneath. So that is actually the end point of the force that is generated during functional activity. Whatever force is generated during swallowing, speech, or during mastication, it is generated because both of the arches are intercuspating or coming in contact with each other. That generates some magnitude of force always. That force transfers to the tooth, through the denture base, through the mucosa, and ultimately to the bone. That force is important for remodeling of the bone when it is within physiological limits always, right? So that is the end point of the force. Any property that is present in the prosthesis, the property which is there in the prosthesis that helps you counter these forces, occlusion forces which are generated, That property is called as support. Support is a property. Support is a property of prosthesis. What I'm trying to explain you right now is very important concept around these simple terminologies that we use in prostho. Support is a property that is present in your prosthesis. The area of mouth or the intraoral structure that gives you support or that helps you derive support. The prosthesis is deriving support from some structure of the mouth. That particular structure is called as a supporting structure. So the structure that basically helps you negate or rather deal with these occlusal forces, help them absorb and dissipate these forces, these structures are called as supporting structures. So I hope it is clear with you. Support is a property that is inherent of a prosthesis. It is not present in the tissue, bone or any structure. It is not present in the clinician's hands also. It is a property of a prosthesis or a ideal requirement of a prosthesis. Any prosthesis should be retentive, should be able to give you support and should be stable. So that is a property of a prosthesis. The particular structure that helps you derive support, that particular structure is called as a supporting structure of the mouth. Now, how do we give support to a prosthesis? There are various steps of complete denture fabrication that will help you derive support, whether it will be your impression when you extend your impression to the limiting structures, extend it as far as possible within physiological limits, or when you select the correct occlusal scheme, or when you select the correct plane of occlusion, you're incorporating stability, you're incorporating support in a prosthesis. So different steps of denture fabrication or prosthesis fabrication will help you give this property or inculcate this property to your prosthesis. So this is a very important concept to understand that will help you now understand what you're reading through your textbook when it says that this is responsible for support or this structure is responsible for retention. So I'll again explain retention and stability to you when the correct time comes, but presently we are discussing support. So that is the first important thing, which is called as support. Now looking at which structures will give you support, the first structure in maxilla which gives support is the hard palate. So if you see a maxilla in a section like this, basically it is a union of two bones. So this will be one maxilla, this would be the other maxilla, and the union happens at the mid-palatine suture. In your vouchers, a line is given that the ultimate support for complete denture is derived from our hard palate. Some of the textbooks also mention that the posterolateral, that means this portion, the posterolateral portion specifically of our hard palate is responsible for support. But if we look exclusively at vouchers, it will say that your hard palate is responsible for support. That is the primary supporting area. Now, why is hard palate your primary supporting area? So, the textbook line which is there for your vouchers is that the ultimate support for a maxillary denture is the bone of the hard palate and the palatine processes. So, why is it the hard palate that is responsible for support? First is the surface area of the hard palate. As you are all aware, if you look at the intraoral structure of the hard palate, of the maxilla, the largest surface area which is present with the hard palate. So that definitely gives it a advantage over other structures in the property of giving support. So the ultimate support is derived from the hard palate. Microscopically, if we see, there are certain features of the hard palate that will help you understand why support is derived from hard palate. Firstly, if we see anterolaterally in the hard palate, the epithelium which is present, it is keratinized. Now we all understand from pathology in general that keratinization is a feature which is desirable for support because of the presence of a layer of keratin. It can absorb and then eventually dissipate the forces very nicely. If it is an unkeratinized or non-keratinized mucosa, there is a chance that it can get abraded very easily. So anterolaterally, the epithelium which is present in the hard palate, that is a keratinized epithelium. Also, if you see, there is a adipose tissue present here. That means fat tissue is present anterolaterally in this region of the hard palate. Posterolaterally, if we see, you see a lot of glandular tissue present. Now, this is a very important MCQ question that comes in the exam. We will just discuss it in some time. And the mid-palatine area that we see here, the mucosa is extremely thin. It is almost such that submucosa is almost absent and mucosa almost is directly attached to the bone only. So it is a direct connection to the bone. Submucosa is almost absent. Basically, if we want to tell, we can define it in one word. It is a non-resilient area. Non-resilient means something that does not withstand or absorb forces. Right, so it is quite a non-resilient area which is present in the hard palate. Now, what are the reasons? The first reason that we saw was that an increase in the surface area which is responsible for your hard palate being the supporting area. Second reason that we see is that there is a layer of compact bone. Now, all of you are very well aware compact bone can help you absorb and dissipate forces evenly, right? So there is a layer of compact bone and then the underlying layer under it is a cancellous bone. So a good combination of bony architecture which is present is that you have your compact bone and then you have underlying cancellous bone. So mainly if you see two reasons or rather three reasons is that good keratinized epithelium with good submucosa on the palatine processes, you have a larger surface area, you have a compact bone, and I can find one more point which is very important is that it is 90° to the occlusal forces or rather perpendicular to the occlusal forces. When it is perpendicular to the occlusal forces, dissipation and absorption of forces becomes very easier, right? So perpendicular to the occlusal forces. So this are our main reasons. If we see, four reasons we have taken into consideration is a keratinized mucosa, then we have increase in surface area, a compact bone, and 90° to the occlusal forces. The reason because of this is why we have hard palate as a primary supporting area, right? So majority of your load will be transferred via your hard palate. Now we come to the clinical implication of your posterolateral area, the glandular tissue that we see. So submucosa in the posterolateral area, submucosa in the posterolateral area contains your glandular tissue. What is the clinical implication of it? If we see a maxillary impression, sometimes you will find small pores present in the posterior part of your final impression, especially with a ZO impression. The reason for this is presence of secretions from the gland. Because there is glandular tissue which is present here, there will be secretions from this gland in the posterior aspect which could lead to small pores or porosities in the posterior part of your maxillary final impression. So when you're loading an impression material with zinc oxide eugenol or any other impression material of your choice for final impression and you press it down there, after removing, you may see small minute porosities on the surface. You might think, why does this happen? It is mainly because of the accumulation of saliva and the minor salivary glands, and this glandular tissue having secreted these secretions that leads to small pores on the surface. How do we rectify is that always before making the impression, wipe the area with cotton or any other gauze or any other material. Just dab it and wipe it and then insert your impression tray into the patient's mouth. So that is one clinical point for your complete dentures. So that was our first supportive structure that we just discussed, which was your hard palate. Coming on to now our second structure that we are discussing, that will be our residual alveolar ridge. Very important. Clinical point of view also is the condition of the residual alveolar ridge, because that primarily will decide how retentive or how supportive your particular denture would be. So what is residual alveolar ridge? The portion of residual bone that remains after extraction of teeth. When extraction is completed, the portion of the residual bone that remains after extraction or removal of teeth, that is called as your residual alveolar ridge, right? So once extraction is completed, a lot of different processes at the microscopic level happens. We will not go into details of it, through which bone remodeling occurs. The socket is filled with a blood clot that is eventually filled with an osteoid tissue that undergoes mineralization, and over a period of time you see soft tissue covering on it. Now this particular ridge that is formed in the mouth, that is called as an alveolar ridge, or because it remains after removal of the teeth, that is why it is also called as residual alveolar ridge. So that is very important. So when the natural teeth have been removed, the alveolus will fill up with new bone or osteoid, which eventually mineralizes and remains there. This residual alveolar ridge is very important to study for two main reasons. The reason is the height and the volume. These are two main important parameters that will determine how good or how better or what is the prognosis of your denture. So height and volume of the residual alveolar ridge is very important. What does it depend on? If we see the general factors on which this may be dependent on, is first and foremost is the systemic health. So while healing is happening, if the patient is the diabetic patient, there is a chance that bone loss can occur. If the patient has vitamin D deficiency, calcium deficiency, bone remineralization will not be optimum. So these are certain factors, briefly if I have to tell you, which will determine how the residual ridge is. Second is gender also, male versus female. Clinically, we have seen that females will have a smaller ridge in comparison to the males. That is mainly because even the arch size is smaller in females as comparison to your males. Third is the forces that are there by surrounding musculature. So forces that are applied by the surrounding muscles will also determine how your residual alveolar ridge is greatly going to be in size, shape and form. Right? Then loss of tooth. If the loss of tooth was because of periodontal reasons, then you will have a bone loss. And so the volume and the height of the ridge will be less. But if it is because of caries, then there is actually no bone loss or much bone loss that we will see. So you'll get a good amount of socket fill over there and a good height of your residual alveolar ridge. Right? And tooth size. If you have larger tooth size that you see, then you might have bulky ridges. So if naturally the tooth size of your particular patient is larger, they are supported by bulky bone. So you will have bulkier ridges for these patients, right? Then if you see how much of trauma was done during extraction with the forceps or the round jaw, that will also determine how much amount of residual alveolar ridge is going to remain later on, right? Not all cases are fresh extraction. Some are previous denture wearers also. So what or how the previous denture was and how was it constructed, what was the occlusion of that denture, that all will determine how your residual alveolar ridge's present condition is. And then relatively, if you see different parts, so relative extraction history, if you see, so if anteriors were removed early on, molars were recently removed, you will see a uneven ridge. So time of extraction of teeth, you will see uneven height of ridges throughout, which is present through the residual alveolar ridge. So mainly these are our main factors that are going to determine how your residual alveolar ridge is going to be for your particular case or patient. The reason why I'm stressing on this is the height and the volume of the bone is going to determine mainly one property, which is going to be retention and support for your denture. So that is very important. Now, if we start discussing, just a second. If we start discussing how the different anatomic shapes are there of the alveolar ridge. So, your alveolar ridge this could be the shape or the anatomy of the palate. It could be U-shaped, it could be V-shaped, it could be flat, or it could be something with undercuts. So we see 4 different morphologies for different parts of the alveolar ridge, right? So the first one that we'll discuss, I'll see if we have a picture here for us to share. I'll just draw it out for you then. So a U-shaped ridge or a U shape is what mainly so the U shape would be mainly a well-developed ridge which will have a palate which is U-shaped and a moderate vault. If I draw it out for you, it will be, just a second. Somewhat like this. Now, pardon my drawing, it may not be very good, but this is how it would be. So the center, oh, sorry. Center of it actually, this particular shape is flatter and the sides are like this. So if I mathematically draw it, it somewhat is a structure that is present in 3 planes and it mainly forms a U shape like this. So the central portion, it gives a flatter surface for the denture to rest or a wider surface for your denture to the rest, right? So this is considered to be, just a second. This is considered to be the most favorable kind of the ridge that has the U-shape anatomy. Is considered to be the most favorable kind of the ridge that has a U-shape anatomy. The reason is what? The center part of it, it offers a flatter horizontal area which will give you which particular property? It will give you something which is responsible for adhesion and cohesion, which is important very much for, take a guess, which property? Retention. So you get a central flat area like this, right? Which gives you basically a surface area for good retention and adhesion. Second important thing is that it gives you a wider area for fulfilling the property of support also. So that is also very important. So property of support and property of retention are very well fulfilled over here, right? So well-developed ridges that we see, these are well-developed ridges. This height of the ridge or the volume of the ridge, if we see these are well-developed ridges, what will they do? They will resist lateral and anterior-posterior movement of the denture. So any movement of the denture that, or rather any movement that occurs, that will destabilize the denture. That will be prevented by the vertical walls of your residual alveolar ridge. So overall, three properties, retention, stability, support, all of these three are very nicely fulfilled by your U-shaped ridge. That is why we call that our U-shaped ridge that we see here, or rather U-shaped palate with a well-developed ridge. It is considered to be one of our very most favorable kind of a residual alveolar ridge anatomy and morphology that we see. The second one that we see now is called as the high V-shaped palate. So if I draw it for you, it will be these drawings are for illustrative purposes. So you will not exactly find a V like this. But the drawing here is mainly for illustrative purpose so that you understand what happens. So in the previous one, it was a 3-planar structure. Here it becomes almost a 2-planar structure. And the central point here, it becomes a point of focus or concentration over which what will happen? There's a tendency the denture can rock over it. Denture can rock over it and eventually fracture and break. So you will see a lot of actually midline fractures with these cases or these V-shaped palates. That is the most common feature that we see. Where is it associated with? You see a very thick bulky ridge. So you very thicker bulky ridges which are high in volume, you will see a lot of your V-shaped palate which is present, right? So thick bulky ridges, you will see a lot of V-shaped palate which is present. It is not a very favorable combination in general if we see. The reason for that is that because the adhesion and cohesion, you don't have sufficient walls for it. It is not very well fulfilled. You don't have particular walls for that intimate contact to fulfill adhesion and cohesion, and because of which actually retention will be compromised despite having good bulky ridges. But the clinical point here that we have to take into consideration is this particular thing, the case of midline fractures that could be there with your V-shaped ridges. So that is something that we need to take into consideration. The third anatomy that we see is a flat palate. We see a lot of flat palate these days in clinical practices also, very unfavorable clinically. The reason is that there is absolutely nothing that gives you retention, stability and support. So from the very beginning only, you need to search for alternate means of retention, alternate means of gaining stability and support. So shallow sulcuses are present here mainly. If you see this part, because there is no vertical height of ridges, you will not see much height of the sulcus. You can have width of sulcus, but height will not be present. Reason is the height of the ridge is not there. This will lead to what? This will lead to a poor peripheral seal. So when poor peripheral seal is there, you will have a compromised retention in these cases, right? So that is for your flat palate that needs to be considered. So the important point here is that they will have shallow sulcuses with poor retention, and so you need to search for alternate means of retention. And we come to the fourth one, ridge with undercuts. Now, this is a hot topic for your exam. If you have read your question banks nicely, you must be knowing that this is one area from which questions have come in your exam. So now I'm again exaggerating and drawing it for you to understand here what exactly is ridge with undercut. If a denture is present, this would be our path of insertion, and the first greatest curvature that it encounters is this particular region, right? So the path of insertion will be here. It will hit at the greatest curvature and will enter into the sulcus. But when you mold your impression material in this particular region, during say border molding or during other procedures also, when you try to remove it out, it will hit at this greatest curvature and it will not come out. Or even if it comes out, it will fracture while coming out. Because the greatest bulk is present inferiorly, there is an undercut that is present superiorly. So if you try to take the impression material out, or if you try to take the denture out, basically the path of insertion becomes such that it will hit at this point of greatest curvature. Now, in such a situation, what do? Can you block the undercut, or do you trim the convexity or the curvature of the bone? What should be your means of solving this particular case? So let's take an example over here. If I see a cross section like this, supposedly my undercut is only this much. This is say my alveolar ridge. My undercut is, let me just draw it out again. Right. So if I extend the curvature superiorly, this is the amount of undercut that I'm negotiating. Supposedly my undercut is very minimal. When I have minimal undercut, what I can do is I can block some part, not everything. You should not block everything. You can block some part of it. So you could block, say, some portion of it while making your denture on the cast, and some can be adjusted with the flexibility of the denture base. So you block some part of it and try to negotiate the prosthesis and seat it. The reason is what? The undercut acts as a mechanical means of retention. So mechanically, it helps with retention, right? So that is about when you have smaller undercuts which are present. These undercuts usually are located where? These undercuts are usually located around maxillary tuberosities, or they could be near your labial part of anterior maxilla. So labially anteriorly is where usually we see a lot of such undercuts. If it is anteriorly, we usually block it on the mastercast with the help of wax or anything while making the denture. And when we are doing the final processing of the denture, at that time we block it out with POP or any cement on the mastercast. But if we encounter a situation now, we'll draw it out here, where you have a supposedly a gross undercut, right? Say my undercut is quite deep. So this would be my entire range of, sorry, this would be my entire range of undercut. As if we see, blocking this much means obtaining no peripheral seal. You would have absolutely no seal. You just cannot block it because the entire denture will just fall down. In such a situation, what do? Do you remove the bulkiness of the tuberosity? Do you try to negotiate? Do you try to change path of insertion? Let's try to understand this. If the undercut is unilateral, this is a question that is asked in your exam very commonly. If it is undercut is unilateral, try to change the path of insertion. So try to tilt the denture or negotiate the denture while seating. I'm talking about bony undercuts here. The textbook or the MCQ sometimes helps or adds an extra word of bony and soft tissue undercut. Now understand one thing, bony undercuts is difficult to negotiate because it is a bony structure. Soft tissue undercut will be slightly compressible over in that region, so you can negotiate or compress it and help the denture insert. So firstly, we need to identify whether it is bony or soft tissue. If we have an undercut which is present unilaterally, irrespective of whether it is soft or a hard tissue undercut, if it is unilateral, try to change the path of insertion of your prosthesis and utilize the undercut by some blocking, so that it helps you mechanically with retention. Supposedly now, if the undercut is bilateral, what do? If it is a bilateral shallow undercut, try to manage it by blocking little on both sides. So you little block on one side, little you block on the other side, and you try to manage it by that aspect. Suppose it does not work like that and you have bilaterally bony undercuts like these, then the next option that comes for us here is to do pre-prosthetic surgery. So this is a question in your exam which is framed in terms of a clinical situation, and the answer is this: if you have bilateral deep undercuts which are bony and you do not get a path of insertion and a path of removal, the option is a pre-prosthetic surgery here, right? So this all in all describes all four varieties of your residual alveolar ridge. We saw ridges with undercuts with a very important key MCQ which is asked. We saw flat palate kind of ridges. We saw high V shaped palate and the associated clinical aspect of it. And we saw the most favorable ridge, which is called as the U shape of your palate associated with your ridges. So all in all, that is about your residual alveolar ridge. Clinically, if you see, the volume and the structure and the height of your residual alveolar ridge will help determine the retention, stability and support that is present in your prosthesis, right? So these are all about your primary supporting areas. Now some of our textbooks do mention maxillary tuberosity as well as your palatine ruge as secondary supportive areas. Boucher's does not exactly directly as such mention it, but we will still discuss our structures as a part of your anatomical structures. So the next structure that we are discussing is palatine ruge. All of you have seen palatine ruge in our patients. You have an incisive papilla here and you see anteriorly these folds of structures which are present. That is palatine ruge. So what are they? Basically they are raised connective tissue structures radiating from the midline. So they are coming from the midline, present where? Anterior palate. So one line, but very importantly describing everything about ruge, radiating from the midline, made of connective tissue and located in the anterior palate. That is your palatine ruge. Most important function of palatine ruge is what? It helps with phonetics. That is a very important key function of your palatine ruge, is that it helps with the phonetic part of your denture. 100% very important point. Second is that it prevents, can you take a guess? forward movement of denture. So consider them like speed breakers that are present, and if the denture tries to slip out of the mouth, the rugae acts like a speed breaker and prevents the forward movement of your denture. So that is a second very important role of your palatine rugae clinically if you see. So two main important aspects of your rugae is that it is important for phonetics as well as it is important for your forward movement, preventing the forward movement of the denture. While making impressions, the most important point that we need to take into consideration with our rugae area is that it should not be distorted. If you distort the shape of it while making an impression, it will cause a rebound effect on the denture, and the denture will rebound and it will dislodge. So that is a key point with regards to the rugae while seeing it clinically, right? So that is your next anatomical landmark for the supporting structures. So all in all, we have covered our supporting areas of the maxilla pretty nicely, which is mainly, if you see what are the supporting areas, we discussed the property of support, we saw our hard palate, right? And just a second, we saw our palate, we saw our, okay, we saw our hard palate and we saw our residual alveolar ridge. Now coming on to the limiting structures which are there of your maxilla, but before that I'll show the supporting structure here. This is your residual alveolar ridge and this part is called as your hard palate. This particular image is taken from vouchers, and though as a student we don't give much importance to it, but it is a very important image because it is a correlation of anatomical landmarks between the mouth and the impression. So what is called as a vestibule in the mouth, what is it called in the impression is a flange. That is very important to understand. What is a labial frenum in the mouth? It is, what is it called as in the impression? It is called as a labial notch. What is a labial vestibule in the mouth is called as a labial flange in the impression. What is a buccal frenum in the mouth is called as a buccal notch in the impression. Then again, what is a buccal vestibule in the mouth is called as a buccal flange. These words are interchangeably used clinically by a lot of students and even clinicians also. But if you have in-depth understanding of the subject, by just these terminologies, it becomes very evident how these concepts are clear in your head. So according to me, a very important image of vouchers that one needs to read and understand what is the nomenclature of these different terminologies that are present, right? So once we finish up the anatomical landmarks, then I can take up these terminologies on your particular image that I have incorporated here, right? So that is all about our supporting structures. Now the next aspect that I will start is about your limiting structures. That is the second part of your anatomical landmarks. Just let me open up the correct page for it. So we will start with the limiting structures here. The first limiting structure is called as labial frenum. So let us begin with limiting structures of maxilla. We'll first discuss what is called as labial frenum. Now what the word frenum means. Frenum basically means a fold of mucous membrane. That is called as frenum. Since it is present on the labial surface, on the inner side of the upper lip, and it connects to the labial surface of the residual alveolar ridge. It starts from the inner surface of the lip and it goes to the labial side of the ridge. That is why it is called as your labial frenum. Now, this particular frenum has absolutely no muscle attachments. So, because there are no muscle attachments, the movements are also very restricted. Hence, you shape or you give a I shape relief in your denture. Maxillary denture. So, the relief would look somewhat like this. You give a I-shape relief in your maxillary denture for the labial frenum because it has no muscle attachment. It could be either single or it could be even multiple. So it could be either one or it could be multiple in nature, but the labial frenum, it looks somewhat like this. And corresponding to it, you give a I shape your particular relief or rather shape of the maxillary labial denture. Mainly it will be the action of the lip that is going to affect the labial frenum. Apart from that, you don't have any particular muscular attachment. So that is your first limiting structure. Second limiting structure, if we discuss the second frenum, is your buccal frenum. Now, this is a very important frenum. Again, the meaning of frenum is the same. It is a fold of mucous membrane. Where does it extend from? From the buccal mucous membrane to the slope or the crest of the residual ridge on the buccal aspect or on the aspect of the cheeks. You will see it on the aspect of the cheek on the buccal side. What does it do? It divides your labial and buccal vestibule. So labial and buccal vestibule are divided with your buccal frenum. Right? What is very important point here is that it could be single, it could be multiple also. So you could find multiple folds of buccal frenum, right? But the most important point is has muscle attachments. Has muscle attachments. What are the muscle attachment that happens or that are present here? Right? In a buccal frenum, what you see is caninus. Caninus basically is a levator anguli oris. So you have levator anguli oris that is present beneath the frenum. You have levator anguli oris that is present beneath it. So if I draw this as my buccal frenum, you will have caninus here. Then in front, posteriorly if you see, you will have buccinator. What will buccinator do? It pulls it backwards. And if you see anteriorly, you will have orbicularis oris that pulls it forwards. Right? So you have your caninus that will be present underneath. So it will pull it down. You have buccinator that pulls it backwards and you have orbicularis oris that pulls it forwards. Together, these three muscles are going to influence your buccal frenum. That is why you need a wider relief for your buccal frenum, or you call it a crescentric. That means it is like a crescent. So you need a wider relief for your buccal frenum because Otherwise, if you don't give, it is going to dislodge your denture, right? So that is about your buccal frenum. The third limiting structure that we have to take into consideration. What all did we see till now? We saw mainly two of our frenums. We saw our labial frenum and we saw our buccal frenum, right? Now, labial frenum, eye-shape relief and no muscle attachments. Buccal frenum has muscle attachment, mainly has your three muscles that we have seen here: caninus, buccinator, orbicularis oris, and you need a wider concentric relief for your buccal frenum. Now let's start discussing our vestibules. So if we see our vestibules, you have your labial vestibule, you have your buccal vestibule. So the one present on either side of labial frenum till the buccal frenum, that is called as your labial vestibule. Mainly it is affected by what? Orbicularis oris. Orbicularis oris is going to affect your labial vestibule because the fibers here of orbicularis oris are going to be horizontal. So it is going to form the outer surface. Mainly it forms your outer surface of your vestibule, and it is the main muscle of the lip, right? So fibers which are present horizontal, that is going to affect the size or the thickness of the flange. It affects mainly our thickness of our labial flange, right? So when we are doing our border molding procedures, we need to mold our upper lip so that the correct thickness of our flange is attained. If you look at our buccal vestibule starts from the buccal frenum and goes to the distalmost aspect of the maxilla. So starts with the buccal frenum and goes distally. That will form your buccal frenum. Now, how is it bound? It is bound by cheek on the outer side, right? It is bound by the cheek on the outer side and internally by your residual alveolar ridge. So internally bound by your residual alveolar ridge. Here also, if we see for our buccal frenum, I'll write it down at this place. Very important point is the thickness of our flange of the denture. If we have a thicker denture, it will usually be dislodged because of the muscles which are present. So you need to do a lot of border molding movements so that your flange of the denture is adjusted here. Now overall, if we see microscopically, features of the vestibular epithelium, it is classified as lining mucosa. All of you are aware you have masticatory mucosa, specialized mucosa, lining mucosa. Mucosa which is present in the vestibule is called as lining mucosa. It is very thin in nature and it is a non-keratinized epithelium. Right? It is a non-keratinized epithelium which is present. That is the main. And it is easily movable also. The mucosa which is present is easily movable in this region. So you need to have a good idea of the length and the form, the movement that is present in the mucosa to make a effective denture. Right? So you have your, if I have to draw your limiting structures now, let's try to draw it. You have your labial frenum anteriorly. Then we just saw our labial vestibule. Then we saw our buccal frenum on both sides. Then we have our buccal vestibule that we just saw and the features we understood. Now we have our tuberosity region. So the next structure which is very important is this that lies behind the tuberosity. What is it called? What is this structure called? Anyone, any guesses? It is called as our hamular notch. So what is basically the hamular notch? The structure or the notch or the displaceable area about 2 millimeters wide, which is present between tuberosity of the maxilla and hamular process of the pterygoid plate. The 2 millimeter wide area which is present here between the hamulus which is present here and the tuberosity present anteriorly, that area is called as the hamular notch. It is your posterior limiting area of a denture. How do you locate it? Locate it with the help of a mouth mirror that you slowly take it across the ridge. You move it across the ridge, and where you feel a depression after the tuberosity, that is a hamular notch. Alternatively, you could use a T burnisher. So a T burnisher, you have two ends of the burnisher like this. You have a ball end of it, right, of a T burnisher. You have a ball end of a T burnisher, and you have a flatter end of a T burnisher. The instrument comes like this. So you keep this portion between your ridges and try to walk the T burnisher. The correct word that we use is walking the instrument. So you move the T burnisher across the ridge, and then where you feel the sudden drop or depression, that is where your hamular notch is located, right? So it will ease into the depression. Now, what are the clinical significant points? Denture should or should not, it should never end on tuberosity. It should always end in your hamular notch region. It should never end on your tuberosity. Then should never go beyond hamular notch. The reason I told you early on, if you extend it onto the pterygoid hamulus, it will cause a sharp piercing and pinching pain to your patient. So for any ridges, for a high well rounded ridge, it becomes very easy, but for a flatter ridge, it is difficult to locate it, but we need to still identify it correctly for good peripheral seal of your denture. Clinically, if you see, it is made microscopically of loose areolar tissue. You see a lot of loose areolar tissue present here, and this tissue is resilient in nature, which means you can apply pressure over it to obtain a peripheral seal. It has good resilience, so you can apply pressure over it and you can obtain a good peripheral seal for your denture, right? So that is about your hamular notch. Now, the region that is located in between that is your cupid bow shape region, which is called as your posterior palatal seal area. So posterior palatal seal. Now this is a separate presentation or a separate topic only that I will be taking it today only in the later part of our session. But all in all, if you unite all of these structures now, if we just draw an outline and you unite all of this, that will make the outermost limit of your denture. So denture will be confined in this central portion only. So that makes up your entire limiting structure of the maxilla. So if we identify it onto our image of limiting structure, let's just start marking our structures. You see first your labial frenum. Then we see a labial vestibule. Then we see a single buccal frenum which is present here. On the opposing side also, I can see a buccal frenum. This is my labial vestibule. Then I have my buccal vestibule here from the buccal frenum. This would be my tuberosity region. Then we have our hamular notch. posterior to the tuberosity, and in between the hamular notch, we will have our PPS region. So if you unite all of them, you form the outer limit of a denture. That is why, since they form the limit of the denture, they are called as your limiting structures of the anatomical landmarks of your maxilla. So that is about your limiting structures. Now we will see the next part of it are your relieving structures, and then we'll go discuss other aspects in your maxilla. So relieving structures, oops. Relief areas, the first one you have is called as incisive papilla. Second is your mid-palatine raphe, and third is what you have is your fovea palatini. Let us identify them onto our image here. In the anterior portion in the maxilla, you have your incisive foramen. So in the anterior part of the maxilla, let us start with incisive papilla. What is it? In the anterior part of the maxilla, just where our central incisors are, you see a papilla-like structure. It is lying over incisive foramen. So it is an opening of nasopalatine nerves and vessels. Nasopalatine nerves and vessels pass through the foramen into the nose. They transfer between the nose and palate through it. Now we are very well aware that we have nerve and vessels passing. If you do compression over it, you will have avascularity of that structure and you will lose sensation, or you will get a numbing feature over that structure. So that is why you should not give pressure over this area. Otherwise, what you feel is a numbness in the anterior maxilla and lip. That is the clinical implication of your incisive papilla. The second relieving area is your mid-palatine raphe. Mid-palatine raphe is basically the fusion of two palatine process. So it is present in the center here. It is the fusion of two palatine process. Now what happens in some of the cases, I'm not saying everywhere, in some of the cases, if I show you a cross section of it, this is one palatine process. If this is another palatine process, sometimes it happens that the union is slightly elevated like this. So this elevated point, it becomes a point over which your denture can rock. It becomes a point of fulcrum over which our denture can rock and then eventually fracture. So this is the reason you need to block it and then you need to relieve it. Sometimes that is the point. Second is that there is almost no submucosa. So if you apply even the slightest bit of pressure, it can actually cause irritation and inflammation. That is the reason we need to block our mid-palatine raphe, right? And third point is our of relief is our fovea palatini. Where is fovea palatini located? Fovea palatini is basically coalescence of some ducts of minor salivary gland that is usually present posteriorly like this. In the midline, across the midline, if you see, it will be present near the midline. In the posterior gastric, you see two small openings. Not visible in all patients, you can see it in some patients. These are what? Glandular openings. These are glandular openings of minor salivary glands. coalescence of ducts of minor salivary glands. In some individuals, it is very prominent. In some individuals, it is not seen at all. Now, what is the clinical implication, right? They are very close to our vibrating line or the posterior palatal seal area. So, they serve as a guide to locate the posterior border of the denture. And second implication is that saliva, if it is thick and ropey, it can collect underneath the denture at this point and it can dislodge the denture. So that is the reason that we need to relieve this area, because if it is a thick ropey saliva, there is a very good tendency that it can dislodge our denture at this particular point, right? So that is about your relieving structures. Now there is one more thing about your soft palate, or rather the posterior palatal seal area, that we need to understand is the junction of hard and soft palate. So you are seeing a cross section here. This portion in the cross section is your hard palate, and this is where the soft palate. This is where the soft palate is starting. The union between both of them, the junction, is usually made of resilient tissue or resilient structures which form the PPS. Some pressure can be applied over this area within physiological limits. So it can help you with retention of the denture. Now there are three classes of PPS. If this junction between hard and soft palate is at an angle of 10 degrees, so that means that soft palate is relatively horizontal, you get a wider area for compressing, or rather the correct word is damping. You get a wider area for damping. So that particular is the most favorable kind of the hard palate soft palate junction, or the most favorable PPS that is available. If this is at an angle of 45 degrees, it is an intermediate level between the class 1 and class 3. You get an average area for damping and for retention. But if there is a sudden fall of soft palate at 70 degrees that you see, then you get almost no area for damping. Now, clinically, if we see, you cannot take any instrument there and measure the correct angle. So, it is very easy to identify class 1 because it is relatively horizontal, and it is easy to identify class 3, which is a sudden drop. There is always a confusion between class 1 and 2 because it falls somewhere in between. But with experience, you can learn the different grades of soft palate junction that are present. And from the first step, you can identify whether or not I'll be able to damp the area and get retention out of it. Damping means applying pressure within physiological limit so that you get a posterior seal and you get good retention with your denture. So, if we come to our images, I'm just having a look if there is any image that we have missed out and not discussed in anatomical landmarks. Yes, so I have included the last image, the first image here, and now if we identify all of our structures, just to briefly revise everything here, we have our limiting structures as labial frenum, labial vestibule, buccal frenum, buccal vestibule, hamular notch, and posterior palatal seal area. Similarly, you can see it on the other side also of the maxilla, right? Then you have a relieving structures, which is your incisive papilla. You have our mid palatine raphe in the center, and you have a fovea palatini posteriorly present, and the general supporting structure would be your hard palate and the residual alveolar ridge. Apart from that, anteriorly, you can see some number of rugae also, which are very important for retention. All in all, this covers all of our anatomical landmarks of maxilla. Now I see it is 6:30. It's about 1.5 hours that we have started our class. You could just take a 5-minute water break and start the class back by 6:40. It's 6:32 right now. You could start back by 6:38, 6:40. Just take a 5-minute water break and come back, and we'll start with anatomical landmarks of your mandible. So we could stop the session here for 5 minutes and start with anatomical landmarks of your mandible later on.